Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Abhinav Deol, who is professor of medicine in the Department of Oncology at Carmel's Cancer Institute at Wayne State University in Detroit. And he's one of the leaders in the CAR-T program, and I am glad to have him here today to talk about the role of CAR-T cells and how it is evolving in lymphoma. We have some already basic 101 videos for those who wish to get a little basic education, but we're going to dive more into the state of the art and how practice is today. So welcome, Abhinav.
Thank you, Dr. Vij.
So Abhinav, so obviously CAR-Ts have been around for a while now. How long have they been around now? For the first thing was, I think, in leukemia, and then we got lymphoma as an indication. So how long have they been around now?
So the initial approval for CAR T cells was in acute lymphoblastic leukemia, as you correctly mentioned, in 2017. And then subsequent approval was for diffuse large B-cell lymphoma. And then subsequently, we had a little bit of a low time in terms of no approvals. And then the next approval was for mantle cell lymphoma with Brexicel, as you mentioned on the slide. And subsequently, more recently, we've had approvals for multiple myeloma. So all in all, since 2017, we've had commercially approved products that are in use currently for patients. And before that, they were available on clinical trials. So at our center, we had clinical trials going back all the way to 2014, 2015 is when the initial clinical trials started off with use of CAR T-cell therapy for different indications.
So obviously we have a number of these products now, and non-Hodgkin's lymphoma is not one disease. So we're going to just try to dissect the different subtypes for which CAR-Ts are approved. So starting off with diffuse large B-cell lymphoma, where do you use the CAR-T cells today?
So with diffuse large B-cell lymphoma, the original approval for the three products, the Axicell, the Tisacel, and Lisocell, was in third-line diffuse large B-cell lymphoma. What that means is patients who failed 2 lines of chemotherapy. Most of the patients initially for this diagnosis would receive a combination of chemotherapy and immunotherapy called R-CHOP. And if their disease does not respond to that or responds and then their disease relapses, the previous standard of care at that time was to bring those patients through salvage chemotherapy or a second-line chemotherapy, and patients who responded then would proceed to an autologous stem cell transplant to try to give them the best chance of long-term disease control. And we unfortunately did not have all patients respond to the second-line therapy that was done before the stem cell transplant. And that was the initial population that was studied with all three products, out of which Axicell was the first one. The studies were ongoing, and then Tisacel and Lisocell studies.